Okay. No, not today, sadly. Got home. All right. Okay. Y'all are all talking and I missed it. Okay. All right. So we're recording. So we're doing spirometry. Okay. Reset. Pulmonary function testing. So it's somewhat like the EKG. When you start having patients that have genetic underlying diseases like cystic fibrosis, or you start having patients with asthma, or you start having patients with COPD, restrictive or obstructive diseases, when they start going to their pulmonologist, and some of you might end up working with pulmonologists, or you start working in certain ICUs or certain critical cares, you are going to administer, or the respiratory therapist or someone's going to administer a pulmonary function test. Okay? And the purpose of these tests is that we are trying to assess how the lungs, how much air they're able to move in normal quiet breathing, the tidal volume. And then if we try to go big and inhale bigger and exhale bigger, how much air can we potentially move? As disease progresses, there are going to be changes where the amount of air you're total moving is slowly decreasing, okay? And because of the way obstructive and restrictive diseases work, sometimes the issue is you can't get the air in. Sometimes the issue is the air is in the lungs and you can't get it out, okay? I don't want you to worry about what kind of disease is what. I want you to know that we do these tests, and because we have assessed people, so you are going to make comparisons when you gather data. The data is going to compare to, for this age, this gender, this height, this weight. We then predict their lungs should be this size. And so the normal readings for this person of this size, shape, gender, size should be this. And your actual readings are showing up this. Okay? And that's kind of how they then can compare, you know, an initial test. From that point onward, anytime you do subsequent tests, because you have an initial test, you can then see the changes in a person's lung volumes and capacities as the disease progresses, because you have a baseline measurement. Okay? Second part of this test is you have to coach a test to get a maximal effort out of a person. If the person just does a half-ass effort and doesn't inhale as much as they possibly can and doesn't try to exhale as much as they possibly can, the test is going to look like they don't have a lot of movement of air and disease is really, really progressed. So if and when you've ever seen someone, or you've been given, or you've watched someone take a pulmonary function test, there is a lot of coaching to encourage, give me a big, 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 big breath, and then exhale, 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 give me that, give me that, give me that, curl it up, force it out. You know, you have to do a lot of coaching with it, okay? This is also one of those tests that, as we've gotten more digitally oriented, the test used to be pretty easy to read and understand. And now, if you look on the third page, it's like circle curves. And it's a little bit more confusing because it doesn't, in my brain, it doesn't read as easy, as user-friendly what everything means. However, the curves give us other data that we can interpret. Okay, so normally this test has this mouthpiece, it's got tubes, and it's connected to this canister, and this water's in there, and the canister moves up and down. And as the canister moves up and down, because you're breathing, the pen is marking on a piece of paper. That's how the test normally is taken in a 2D method, okay? And so when you read the pen, this should be the printout that you get. All right? And so when we ask someone to breathe in a normal, quiet fashion, when the pen's going up, that would mean inhale is occurring. When the pen is going down, that means exhale is occurring. And the little bleeps of up and down in this first little middle of the graph area, those are going to be your tidal volumes. And again, for an average person, normal, healthy, male, female, we tend to put the tidal volume is about 500 milliliters. Okay, so 500 milliliters of air. How much is your soda can? Does it say if it's 400? The bottom, does it say on the bottom like how many milliliters is in there?
Oh, 355.
Okay, so for most women, that soda can is a little bit less than a half a liter. That's more of what a tidal volume shorter women have because their lungs are smaller. Okay, but again, we normally say people move about half a liter. So if you go and you get a standard water bottles like I forget the brands. You have one? Yeah, Aquafina. That one should be 500 mils, right?
It is.
So if you go and you look at a standard water bottle, that is normally 500 mils. That is normally the amount of air we inhale and exhale out, normal quiet breathing. Okay? So that is known as your tidal volume. Now, that breathing, remember, is active inhalation. The diaphragm is pulling down. The intercostals are pulling the ribs apart, lifting the clavicle. That is an active inhalation, a passive exhalation. That is not quite getting my scapulas to turn, to get my shoulders to open. That's not quite lifting my chest or lifting my clavicles. And that's not quite really moving more as much as possible my rib cage, my serratus anterior, my other muscles to get more mobility out of my chest. So if I want to see, can I get more air in? Can I take a bigger inhale? That is going to be represented where the top of the tidal volume normally is. You go all the way up to that peak. That is known as your inspiratory reserve volume. And that is you, if you have very compliant lungs, very mobile bones, so we're not brittle old people. We have good connective tissue, cartilage, collagen. We can then, again, open our chest, pull down, mobility in our scapula, mobility in our shoulder, mobility in the clavicle and the mambrium, mobility with the ribs. That is the amount of air we can get in when we really try to push it. And again, this is when you coach someone to give me the biggest inhale. Pull it in, pull it in, pull it in. And again, it's somewhere around, I think, a liter, 1.2. I mean, I don't know the numbers off, but they're listed in your book. All right. And again, guys will tend to be able to probably take in more because guys tend to be physically bigger. Okay. Then when you do a big exhale, if you go as much as you can, when you get to below the tidal volume and you go down and you engage your rectus abdominis, transverse abdominis, your obliques, you engage your muscles and you even curl into yourself and you get air through active exhalation and you force as much air as you possibly can, trying to let some more of those elastic recoil forces and surface tension have a little more go than they normally do. That's going to give you that expiratory reserve volume. Okay, so you have tidal volume, you have an inspiratory reserve volume, and you have an expiratory reserve volume. Even with trying your best, you should never see the trachea close off. You should never see the primary, secondary, tertiary, quaternary, cinquiary, septenary. I don't know how to keep going, but you don't see those major airways completely block off. Your alveoli don't completely deflate. We cannot directly measure that unless we put tracer gas and we have imaging and we make you breathe the tracer gas and we image it while you stand there breathing. That's very complicated and we're not going to be able to do that normally. So the residual volume is the volume of air that even as much as you try, you should always have this air left in your lungs. And this is the volume that is a mathematical estimation going back to what is your age, what is your height, what is your weight, what is your, again, health status, female, male, okay? That residual volume is going to, when disease progresses, is going to typically increase. And as it increases, that means more air is sitting in your lungs and not leaving. And so that means less air is actually moving in and out. Okay? And that becomes a problem because as less air comes in and out and more air is staying in the alveoli, you mix those two together. So when you mix more residual volume air, then you're going to see the partial pressure of oxygen slowly go down because you're mixing it in with more carbon dioxide rich air, so it can't quite maximize out to that partial pressure of oxygen of 100. Okay? All right, so you can technically abbreviate tidal volume as capital T, capital V. You can abbreviate inspiratory reserve volume as IRV, expiratory reserve volume as ERV. Okay? And then residual volume can be RV. But to be safe, you should always spell them out. Okay? All right. Now, when you take a pulmonary function test, and it's not as clear here where exactly is me forcing the air out versus letting it out naturally. So that is why the more up-to-date, newer readouts of the test show you inhales as coming in, exhales as coming out. Okay? And when you look at again, the slope of the line of exhale, that is when you can start to really see in a forced expiration, how much air am I moving during the whole period? And then because normal lungs, the biggest pressure gradient comes at the very beginning. So usually the more powerful exhaling amount of air comes in the first second, the first 25% of the exhale versus the first 50% versus 75%. So in general, most of us will exhale out 3 to 4 seconds. So we would expect to see most of the air exhale out in that first second or that first 25th percentile of time spent exhaling. Okay, so your forced expiratory volume is normally related to when you're doing a pulmonary function test and you're really trying to force out all of this air that you've inhaled. Where is most of the exhale taking place? And most of it takes place in the early, all right? And so when we look at that, we will usually pinpoint into what's your forced expiratory volume, how long does it take you to do that, and then how much of the air are you moving either in FEV1, the first second, or depending upon if there's exhaling out for maybe 8 seconds, all right? How much are you blowing out in the first 25 percentile of time? Okay, so that might be when you see FEV and then they have a little 25%. Now, the reason why that becomes important, all right, is because when you have obstructions and restrictions, depending upon how the disease is progressing, like I said, some people can get air into their lungs and it's really hard to get the air out. So they have to kind of like really slowly, long exhales, all right? And so for them, the forced expiratory volume is going to be very long, and they're not going to get air out quickly in 1 second. They're going to get it out over a long time. So that's going to be diagnostic-wise how you start to tell some of the different pinpoint into if the person has asbestos and emphysema versus COPD. Again, for your purposes, you just need to know what FEV1 means versus what FEV is and what IRC, ERC, or ERV, IRV means, okay? So you don't have to diagnose anything. And the only reason why I put this on here versus this is so you can kind of tell the information on here is the same information on here. It's presented in a different way. And for many of our brains, like mine, I don't understand this. I understand how FEV is more clear on here, but other than that, this is not intuitive to me. This is. And so I would prefer to see everything this way. But nowadays, everything comes out as the circle graphs. Okay? And again, the circle graphs, especially with diseases that FEV1 is a big diagnostic tool, they are going to be better at basically catching certain disease progressions versus this. So that's why everything is moving towards these printouts. You will be held responsible for this because this is the one in your book. So this is the one you have to learn. Anything not on here, like FEV, FEV1, you have to learn the words by what do they represent, what do they mean. Okay, the next thing we have to learn is the capacities. Now, when two or more volumes add together, you get a capacity. So, anytime you are inhaling, which is in tidal volume and in inspiratory reserve volume, if you add those two values together, they will give you an inspiratory capacity. They represent the total amount of air you can get into your lungs. All right? When you add in inspiratory, tidal, and expiratory reserve volumes, those three represent what is potentially your vital capacity. That means the amount of air you move to live and breathe if you have to. All right? Functional residual capacity is when you are tidal breathing, you are leaving in your lungs residual volume and you're leaving in your lungs expiratory reserve volume. So for most of us, when we're not trying to breathe out the expiratory reserve capacity, it stays in with the residual volume. So those two become your functional residual capacity. It can decrease as I push and get my expiratory reserve out, but for the most part, it is going to be what is generally with quiet breathing left in your lungs. Total lung capacity is everything. And again, because you have to guesstimate, you have to estimate mathematically, maybe determine what residual volume is, there'll be a little bit of error in total lung capacity. Okay? So those would be, again, the terms listed next to the graph you need to be able to identify. Now, this will be in color, like it is in your book, when you are presented it in your test, in your lab test. All right? So you can, I think, so it's green down here and green, so that's your residual volume space. Then this is pink, so that's the expiratory reserve capacity, and then it's white for tidal volume, and then it's purple, it looks like, for inspiratory volume. So there's some colors to help you as well. Okay? All right. Now, the directions for how to do this, you are not responsible for, but if we were able to do the experiment, it would give us a printout that would look kind of close to what the spirometry with the water basin should look like. So again, it's not, it gives us, they tell you to take 1 to 2 breaths, big inhale, big exhale, and then we would plot that material and try to calculate volumes. Because the stylus doesn't work or the computer doesn't work or it has bugs in it, it doesn't work really well, so we don't have time to do that. But just note that I am working on one day trying to get different stuff. All right. So if and when you want to look at what is your lung capacity, you should hopefully, unless you have some underlying condition, or you are a smoker, or you are exposed to a lot of secondhand smoke, because all of that is going to degrade more quickly your connective tissue of your lungs, connective tissue of your chest wall and cavity. If you've had open heart surgery, if you're wearing a corset, if you wear very restrictive clothes and you try to take this test, all of that would potentially make your values less than the average for your age, for your gender, for your system. Okay? But for the most part, the book provides some general female, some general male rules for healthy young people. And most of you should fall into that. All right? And that is that. So, questions on pulmonary function testing. All right, so again, expect a station on your lab test with about 3 to 4 questions over identify the indicated volume or the indicated part of the graph. What does it represent? So you would need to be able to tell me either the volume or the capacity that is being represented. All right. And then on the lecture test, expect either matching or fill in the blank questions that might give you the definition of the volume, the capacity, or the term, and you have to pick the answer that goes with it. Okay? There is no diagnosis. There is no disease items to memorize. There's no like ratios that you need to know, numbers you need to know. Okay? And then remember in your ADILT lab, one of them is really short. The other one, I actually forgot to put it on there, so I opened it up. So you only have to do one of the activities to get the 5 points this week, but there is 2 activities to do. Okay? So if you just want to practice and see more, some of those activities, again, are going to make you do pulmonary function tests and assess pulmonary function tests and read them. We're not reading them. We're just trying to make sure we get the idea of what the values are. Day 1, when you walk into, again, your nursing class, they are going to expect you to know what these things mean and start finding and figuring out and working your way kind of down the little flow chart to, if this number and this number are less than normal, this is potentially what the disease is you're dealing with. And so you have to start to think, okay, what does this number represent? If it's lower, then this value is lower. This is not happening. So that's why the disease is this. Okay? That's where you're going eventually. All right, questions. Well, I mean, if you put at least if you don't spell volume or capacity or something, but just remember, if you don't spell it all out, it'll probably mark it wrong. And then because the answer is all spelled out. But if you're getting tight for time and you just put the initials, it will probably still mark it wrong, and I will go through and probably mark it right.
So we can just like put the initials.
You could, but it's going to mark it wrong.
Okay.
Because technically I've asked you for the full term.
Okay.
And if you put inhalation instead of inspiration, I'll probably give that to you. Okay, and if you put expiration or exhalation, I'll probably give that to you. You know, so I'm pretty much, as long as you demonstrate to me, you understand this is inhaling, this is exhaling, this is residual, or, you know, and if you are worried about time and you just put the initials, again, if you're taking the paper test, I'll hand grade it, but if you're doing it online, it's gonna mark it wrong, because the answers on the online lab test are that you write it out specifically. It will definitely mark it wrong. So I'll have to, so don't freak out and know that those 4 answers, you will most likely get points back when I manually grade it. Okay, any other questions? Okie dokie. All right, what do y'all want to review first? Y'all want to review respiratory or you want to review lymphatics?
Look, can we do lymphatics?
Lymphatics. All right, here we go. Let me get some lymphatics. All right. So, what is this opening here called? If I put the sticky here and I say identify this lymphatic feature. Right? Lymphatic
duct.
duct. So then if I put the sticky note over here, what is it?
The thoracic duct.
Thoracic duct, yes. Don't say left, because technically there's a right, but there's not a left. Okay? All right. Name me 3 lymphatic organs. Spleen?
Yeah, thyroid.
Not the thyroid. The thymus. And then all the others would be lymph nodes. Okay? So 3 lymphatic organs are your thymus gland. Purpose of your thymus gland, somebody online. Why do we have a thymus gland? Somebody online. I'm going to start calling on y'all. Okay, I'm going to call on. Well, let me see if anybody answered it. Is everybody frozen?
Is it?
What? Denisha.
Is it like the because it's like the primary, it's supposed to be like a primary, it's the primary organ for, is it like the primary organ for the lymph nodes or something like that?
So thymus gland is the primary place where what cells go to develop?
Oh,
the T cell.
Oh, the T cell. Okay.
Right. So because of the T, the thymus, that's where T cells go to mature. And what's the buzzword that we say T cells get when they're in the thymus gland? They become immunocompetent. And immunocompetence means what? If you're immunocompetent, what can you tell?
Which one is yourself?
What is self and what is not self? Okay, so that's where we believe the T cells go to become immunocompetent and mature. Okay, all right. Spleen, tell me about the spleen. Somebody online, Denisha is off the hook.
I know that's the largest organ. I know that.
The largest organ, okay, but it's the largest lymphatic organ, but what can you tell me about Mr. Spleen? Denisha, you're off the hook. Make somebody else do it.
Okay.
All right, I'm gonna pick somebody in 3, 2, Jessica, I see you're bleeping.
Doesn't it filter the lymph?
Not the lymph, because the spleen is going to get to filter what?
It removes abnormal blood cells.
Abnormal blood cells and any potential pathogen in the blood. Okay, so it's kind of unique too, because it's not really worrying about lymphatic fluid. It's getting to do blood. And it's removing red blood cells, as Maria Christina told us. And it's also getting to filter anything in the blood that potentially pathogen-wise has been pretty interesting at getting past all of the other mechanisms and is now a blood-borne infection. Okay? All right, let me make a little room to put Mr. Leg Guy up here. Okay. And then, can we see these hopefully? So these represent our lymph nodes. And again, they don't get any special names. All right. And the vessels that come into the lymph nodes, there's usually maybe 2 or 3 of them. Those are known as you're going in, afferent, and the exiting is the, and everything for blood vessels and usually that efferent vessel in the lymph node and the spleen comes in and out in one location. The helium, the hilus, the hilum is that Latin term. Okay? All right. Now let's go through what's the difference between a lymphatic tissue versus a lymphatic organ. All right, somebody online. Tissue versus organ. Who wants to do this one?
Isn't it that
I can
they're
take a guess. Go ahead.
isn't it that they're like separated by something?
So they have that distinctive capsule.
Yeah.
So they kind of have that connective tissue, irregular capsule, and then they have those hilums, those hilus, those entry points for usually an artery and a vein to come in and out. And if nerves are going to come in, they're going to come in that area as well. And so they kind of have this dedicated little like access point for things. Okay. Whereas tissues do not have that defined definitive stuff. They're just this large kind of clumping of cells, T cells, B cells, mast cells, macrophages, neutrophils, whatever the immune cells are. And they kind of come and kind of congregate, and they're sitting right behind the epithelial tissue, and they kind of make a little spot for themselves, and it kind of elongates out the areolar connective tissue. Okay, and so we have, what are some of the lymphatic tissues? The malts and the Peyer's patches, which are part of the digestive system. The tonsils, I think that's kind of it, right? Okay. All right, and the tonsils, what are the three pairs? Maria Christina, you saying them?
Palatine.
Palatine or palatine?
Palatine. The lingual.
Lingual and pharyngeal.
Yep.
Okay. And when you do digestion, you're going to have three pairs of salivary organs that are very similar. So make sure you separate them out. Okay. And the salivary glands are not technically organs either, because they're just a lot of glandular tissue in this area behind epithelium that pushes into saliva through a duct that then makes it enter part of your mouth. Okay. All right. You do not have to know malts or Peyer's patches, anything specific, but they do connect to capillaries that are sitting with the capillaries of the blood supply in the GI tract. What do we call those capillaries inside the lymphatic system, part of the digestive tract? It's the only time we name vessels in the lymphatic system. What do we call them when they are sitting in the digestive tract? Starts with an L. Lacteals, yes.
Yes.
They are in the they are the capillaries of the lymphatic system that are right in my small intestine. Here it is. Okay. So in this model, which is part of next time, you can see the simple columnar of the stomach, simple columnar of the small, simple columnar of the large. The capillaries in these connective tissue areas behind these cells, the lymphatic ones are called the lacteals, and the digestive or the regular blood ones are just called capillaries. Okay? And why do we need the lymphatic system to help the digestive system? What is it that is really, really important that the lymphatic system help us absorb?
Absorb the
Well, it helps us absorb the lymph fluid to bring it back to the cardiovascular system. But what from our diet does it need to help us?
Lipid.
Lipid, specifically things like cholesterol and triglycerides. Because if you try to put cholesterol and triglycerides in water, they're not going to want to go in there because they need to be wrapped with protein. Well, when they come across the cells and they're in that area, in the extracellular area behind the simple columnar, the small, the large, the stomach, they can't get easily into the blood supply because endothelial cells are, blocking them. And it's hard for them to go into solution because they're fat. So they form these like fatty little, everybody's put oil in a pot of water, right? You know how it makes little like balls? Right? So they form these little kind of mycelials, these little fat globular blobs, and they go into the lymphatic system. And then the lymphatic system takes it to the liver. And then what happens in the liver? The liver cells wrap the fat with protein, creating LDLs, VLDLs, and HDLs. So that way that blob becomes more compact and becomes more water friendly for traveling in the blood supply. And that's how you then distribute the fat. The other thing the liver can tell, and this is some of chapter 25, is you ate a lot of fat in your diet, so I don't have to make cholesterol. I don't have to make as much fat for you to distribute to cells that need to make fat for hormones or cells that are trying to make more membranes, organelles that require phospholipid, triglycerides, steroids to do that. So the liver can then kind of go, okay, I don't have to make fat, and I can take some of these fuels that I would use to make fat and convert them to other things because I'm getting fat from my diet. Okay? So the liver would like you to eat a little bit of fat. That's why if you go back and you look at heart-healthy diets, they always say cut the fat so you don't have to make a lot of fat and you're not bringing a lot of fat into your system, but have a little bit of fat in your diet so your body gets what it needs to be able to make any steroid hormones, estrogen, androgens, aldosterone, cortisol. But it doesn't have to make a lot of fat to be able to then supply that and supply phospholipids to growing cells. Okay? And if you don't have as much fat, then the liver also can make more of the fat wrapped in the HDL proteins. And maybe then you have less LDL proteins that will then get picked up by cells in the endothelium and deposit the fat inappropriately in the long term in your vessels, causing the vessel to slowly occlude itself. Okay?
So how people lose weight when they go on the keto diet?
So anybody that loses weight is going to lose weight by having calories in less than calories out. So every diet, no matter what the diet is, always usually has a calories that you're taking in or less than calories out. Okay? And then every diet then tries to manipulate by the foods you eat, potentially which fuel of energy. Do you burn glucose and carbohydrates? Do you burn lipid? Do you burn protein? Based upon which ones you give it. And a keto diet is you cut so many calories that your body doesn't let you use your carbohydrates except for your brain, and you burn fat and protein, and you have to somewhat make carbohydrates to make more sure your brain works. And in doing so, you're burning those things very, very quickly to meet demand of your body. But it's a slippery slope because if you stay too extreme on that diet, you'll become acidotic, and that can kill you. So a little bit of acidosis is okay, not too much. All right? Right, and again, some people, so diabetics, they have diabetic ketoacidosis. When they get sick and they can't eat and they can't get their insulin and their glucose is messed up, their body goes into an acidotic state, and that can kill them. And then people who are super anorexic, part of the reason why they can die is they become so acidotic from basically being in ketoacidosis, they can die. And their organs can go into failure. Okay, but any diet, every diet, they're trying to first get you low calories, and then they're trying to tweak things. So Atkins says, eat all the fat and protein you want, don't eat any carbs. Heart healthy diets usually say low fat diets, you know. So everyone has its little trick, and none of them are 100% effective and perfect, and none of them are the cure-all, end-all, because if there was one, what would we all be? Healthy, and we wouldn't be still becoming obese. And every one of them takes discipline and no more eating out. Because every time you go and eat out, you take in more fat, more salt, more preservatives. Okay, we got off topic there. Okay. Did I cover everything in lymphatics? The cells, right? The cells, I think, is the only thing, but hopefully you can go through the blood board. Questions on lymphatics? Any other questions on the system? Did we cover everything?
Does the lymphocytes on tissues and organs?
Depends. And it depends even in the lymph node. So the question is, are there the same amount of lymphocytes in different places? No. So it depends. And then remember in our lymphatic nodule or our node, when you first come in with fluid, you're probably going to hit a lot of dendritic cells or macrophage-like cells. Then you're going to hit a lot of B cells that have already been activated to make antibody. And you're going to try to get with, do I know what you are? Can I eat you? Then you get to the T cells. So the cortex of a lymph node might not have as many T cells, and it's very rich in B memory cells and plasma B cells. Cells that are already activated and making antibody, and the fluid should pick up a lot of antibody as it flows through. The center, the medulla, would then be full of naive B cells, cytotoxic T cells, T helper cells, or if you go by the theory that the T cells are all undifferentiated until they're activated, T cells. Okay? And then in the spleen, you're going to have, again, little pockets of white cell-rich environments, and the red blood cells are flowing. So you want your, again, macrophages kind of to be out there bumping into as many red blood cells as possible. And maybe your B and your T cells are kind of holding on at their anchor point and are going to only interact if the macrophages bring stuff over to say, look what I ate. Is it good or bad? And then the B cells will be shooting out its antibodies to go travel with the rest of the blood supply and disperse. Okay. I don't normally ask you, like, are there more B cells in the blood versus T cells? I wouldn't worry about that so much because I want you to know what T versus B cells are. Okay. And again, for your adaptive immunity, when you are naturally bringing in a pathogen, so that would be naturally exposed, that's you touching the doorknob, touching your face. That's you eating food that hasn't been cooked all the way. That's you letting the tick or the thing bite you or bed bug bite you, you know, and inject you with virus, bacteria, whatever. All right. Active immunity is eventually your T cells figure out something is foreign, turn on the B cells, and the B cells start to create immunoglobulins against this pathogen. You do not have to be able to tell me if the pathogen's going to end up creating IgA, IgG, IgM, IgE. I'm not worried about that because, again, that's more microbiology that is beyond us. But know that when the B cell gets activated, depending on what that pathogen is, it does somehow splice and dice its genes and its DNA. So it will forevermore make almost exclusively like IgG and IgM. And the IgG and the IgM will always be to this pathogen. Versus a different type of pathogen, it might be it always makes IgE. And that's the antibody. So there's a lot of intricacies that hopefully you get in micro, or hopefully one day later on you get in a more advanced virus or bacteriology class. Okay? If you can tell me that the antibodies will be made by the B cells, and that's part of that humoral immunity. All right, so again, in medieval times, they would bleed people with leeches because they needed to correct their humors. Here's that carryover from that terminology from barbaric leeching of people. The blood is a humor, the blood, but any of my interstitial fluids have antibodies in it. Those antibodies come from B cells. The antibody's purpose is not to kill, but to attach so it can make the target bigger. And either natural killer cells, macrophages, eosinophils, neutrophils, cytotoxic T cells come in, or things like complement come in, and once the antibody is tagging and making the target bigger, either spit on it, break it apart, and eat it, and break it away. Okay? All right, questions? Okay. Ready for respiratory next, right? All righty. What are your landmarks? Think of the nasal cavity. What's the superior border of the nasal cavity? Cribriform plate of the ethmoid bone, a little bit of the frontal bone with the frontal sinus, and maybe even a little bit of the sphenoid bone with the sphenoid sinus. What's your anterior landmarks of the nose? The nasal, the nares, external nares, okay. What separates the nares from the right and the left side? The nasal septum. And does everybody automatically have a septum that separates things equally? No, because if they didn't, then we wouldn't need nasal septum nose surgeries, right? People get those surgeries all the time because their septum grows to where one side's more open than the other. Okay? All right, what's your inferior border of your nasal cavity? What am I going to put tile on the floor of?
The bottom.
The hard and a little bit of the soft palate, which is where the uvula kind of comes out of. All right. And what is some of your landmarks back here in the back? If you had the external nares, then it would be internal nares, and then the opening might be a little bit of the vestibule. All right, what are some of the big landmarks inside the nasal passageway? The superior, middle, and inferior bones, or the conchae, and the tunneling between them is the meatus. Okay. All right. What type of lining do we tend to have in the nasal passageways? What kind of epithelial lining is in here? Did I ask you that? It's a mucosa, but it's a mix. There's going to be places where it's going to be stratified for sure because it's located near openings. But in other areas, we should have probably some columnar, especially where the olfactory areas are. And then to make mucus, we're going to have some goblet cells to help secrete mucus. All right. Okay, what's the next part of the respiratory system? What does the nasal passageway connect to? Not directly to the trachea.
Nasopharynx.
Nasopharynx, then the, what other part? It's the pharynx, all of it. Orthopharynx, then the laryngeal pharynx. And then when the pharynx ends, what's the next part of the system?
Thyroid.
Not the thyroid.
Thyroid. The H.
This is the larynx. All right, and some of the features of the larynx. What is this bone that's freestanding? The hyoid bone. What is this? Okay, for the online, what is my flappy? It's gonna, when I swallow, it's gonna close off my airway. What is this? Good, Erica. The epiglottis.
Epiglottis.
What is this prominent, online people, what is this prominent piece of cartilage right here?
Is it the carotid?
The little Batman, the coracoid is right here. So this one is the one where the gland sits and covers part of it. So it would be your correct, thyroid cartilage. All right, and you connect cartilage and bone to each other by ligaments. So this would be the hyoid, thyroid, ligament, and then the thyroid to the coracoid. And again, I think the coracoid looks like a little Batman signal. But on this model, we cut off half of it and we have the thyroid gland in front. This protrusion right here is what we then see in males very prominently. That's what we see the Adam's apple is. Okay? Now, in here, there's the little like chicken claw, and then there's the other little piece. Which one's which? Which one is the articulate, or corniculate? Which one's which?
Bottom one is the flora.
I think that's right. I have to always look it up. So that means the chicken claw is the, because again, doesn't it look like a little chicken claw right there? What's that one? Come on, somebody. I know it starts with an A. But it's listed as one of the pieces of cartilage you have to know. Anybody? Arytenoid, something like that. Did y'all find that?
Yeah.
Okay. And then these two cartilage are going to play a role with controlling the vocal folds, the vestibular folds, the vestibular and vocal ligaments, all the pieces and parts that are like broken off in this model that form what we then call your vocal cords. And the opening between them, that little epiglottis covers, is known as what? That's just the glottis. And you manipulate the glottis and how much opening there is by manipulating the two pieces of cartilage here, which then manipulates your vocal and your vestibular folds and ligaments. And as they manipulate, the glottis can be more open, less open. They can have a thickening, they can have a thinning, and that then gives you the range of ability to sing or make notes or your vocal range. Okay? And again, if this connective tissue becomes more like collagen and like kind of scar tissue and toughens, that's considered for like singers deaf, because that means that pliability that gives them their range decreases, and that's why vocal nodules, and they might try to go in and cut away that growth or that thickening or hardening of the vocal fold or vestibular fold. All right, and then they have to do exercises to keep that pliancy, keep that elasticity. All right, what are these rings just known as? I put a sticky here. You would say these rings are either which letters? A C ring or a U ring. So the rings are not going to touch each other. So what's going to be between them? That is a muscle that helps make them between C's and U's. So it opens them and closes them as needed. What is this muscle? Starts with a T. That's the trachealis muscle. Okay. And again, ligaments between these are just known as tracheal ligaments, right? All right. What kind of cartilage are the C or U rings? Is this fibrocartilage, elastic cartilage, or hyaline cartilage? Somebody online. Coy, what kind of cartilage? Pick. Fibrous, elastic, or hyaline?
Can you repeat?
What kind of cartilage is the C ring? Is it hyaline, fibrocartilage, or elastic cartilage? Which one? You got a choice. Hyaline, elastic, or fibrous? Fibrous, collagen rich, fibrous. Pick.
I guess the first one.
Hyaline? Hyalin, hyaline. Tanya is nodding her head yes. Do you want to agree with Tanya?
I guess. Yes.
Yes, that is correct. What kind of cartilage is the epiglottis and more of these manipulative areas around your vocal cords? They should be more what? Elastic cartilage. Okay? So, more elastic here. And then when you get into the trachea, it's going to be more hyaline cartilage, okay? You don't want too tough because we want to have a little bit of that mobility and movement. All right, one of my Allisons, if you're still here. Allison, what kind of lining, epithelial lining is in the trachea?
Simple squamous.
Not quite simple squamous yet. That's going to be more in the alveoli. We still want mucus, and we want some ability to take mucus and beat and push it up to the area up here so it can be swallowed. It's pseudo-stratified, ciliated, columnar epithelia. And remember, this is one of those really unique places where we have pseudo-stratified ciliated columnar epithelium. And embedded in there are going to be goblet cells. And that is going to create mucus, so the air, after it's gone through the nasal, gone through the pharynx, gone through the larynx, it's still being cleaned. It's still being purified. And the mucus is taking those molecules, and then the cells with cilia beat, and that mucus goes up, and you swallow that mucus. And you need to swallow it every day, okay? Because you don't want that mucus to fall into the lungs, because then it'll thicken up the distance the oxygen and carbon dioxide have to travel. And remember, the pathogens in there are now in warm, mucusy, puddles, and they'll start growing and propagating, and that'll cause pneumonia, and that can kill you. Okay, good job. What's the bottom of the trachea known as? Where it forks? The cornea. All right, and then you go into the primary bronchi, and then on the left side, you're going to go into how many secondary bronchi? 2 or 3? Left should be 2 because the heart's over there. And so that means how many secondary bronchi do I have on the right side? 3. Because how many lobes do I have on the right lungs? 3. I'm coming. Trying to get off of this. All right, somebody online. What's the top of the lungs known as? Up here. Denisha, Deanna, somebody, Allison, who, what?
The apex.
That's the apex. So then tell me, what is this part down here known as? The base. What's another name for this inferior border? Because what is it going to connect to? The diaphragm. So what's another name for it? The diaphragmatic border. What's the anterior border sometimes known as? It is touching the ribs and the cartilage, so it is known as sometimes your costal border. Okay? And what's the entrance point known as? Don't tell me. Know that because you already named it. Somebody? What's this? We said it earlier. It's an entry point for blood vessels, for the bronchi.
The hilum.
The hilum or the hilus. Okay? All right, this is my left lung. So what is this little notchy thing, intrusion here known as? The heart's there, so what would it be called? The cardiac notch. And what is this line that you see separating the lungs into kind of a top and a bottom? It should be the oblique fissure, right? And it separates it into what two lobes? Superior and inferior. Here's your right lung, Sean, you're jumping ahead. All right, so there are 3 lobes here. I'm trying to get the angle right for the picture. All right, so the line that runs kind of east and west is your horizontal. And then the one that runs kind of like your hands going in your pockets, somewhere in here, is the oblique. And you get 3 lobes, so we call them the superior, middle, and inferior. Medial I would accept because that's kind of the same thing. Okay, and again, when people are in shock, we tend to roll them onto their left side, right? Part of that comes down to, theoretically, you have a bigger right lung than your left lung. So if you push them over to the left side, any fluid is going to pool more, hopefully, in the left side, and you would have more airway in the right side to get more oxygen potentially to them. Now, if they're a smoker and they killed half their right lung, you know, they're screwed either way, but you're hoping in theory that most of us have a little bit bigger right lung. So in theory, if we can get more air into that right lung and we get whatever fluid or whatever is maybe pooling to go down to the left side, we would get still oxygen rich air, hopefully more so into the body that way. All right. Pleural cavities. What's the outer membrane known as? Parietal. Pleural membrane. So that means the inner one touching the lungs is the visceral pleural membrane. You have simple squamous alveoli lining, simple squamous cells lining the alveoli. You have simple squamous cells as part of the visceral and pleural membranes. But what do I call the visceral and pleural membrane simple squamous cells? Just like I did in the pericardial membrane. They are, if you or anyone in your family thinks they have mesothelioma, please call. What's it called? Mesothelium. So every time they do those commercials about, do you or anyone in your family have mesothelioma? Were they exposed to asbestos or hazardous chemicals and they were not wearing proper equipment? That those chemicals, that tissue that got degraded, got damaged, turned cancerous, is the mesothelium. That's that simple squamous of the visceral pleural membrane or the parietal pleural membrane or the visceral pericardial membrane or the parietal pericardial membrane. And if they overproduce too much fluid, then I have another issue of compliance. Because if there's too much fluid in that space, will the lungs push away and the ribs pull away? And will I have as much ability for movement in and out? No. And so I will decrease my ability for total lung capacity, vital capacity, inspiratory, expiratory volume. And that pushing will start to even make it harder for me to probably inflate my lungs because they're not able to get as much mobility open and it takes greater pressures. All right, questions on our review of, what did we just review? Respiratory. All right, gang, next week is a big week. I mean, we have a lot of, we have teeth, we have histology models, lots of histology models. We have mouth, livers, pancreas, small, large stomachs. We have a lot to go over. So do be prepared that it's probably going to be like this, about an hour and a half of material. And as I go through it, I'll be throwing in some physiology stuff to help. All right, if you do not have any more questions, I'm going to stop the recording. And I will